Let me see. I think it's record. It's still recording. It's like, okay.
I think so. Yeah. Okay.
Okay.
All right. Straight face. Uh, Patient is a 35-year-old female with a
Okay.
history of a polytrauma with multiple fractures to bilateral lower extremities after a motor vehicle collision that presents to your clinic for left lower extremity pain. What would you like to know about their history?
So I would like to know the onset of the trauma. We know the mechanism of the pain. I would love to, but I would love to know the onset. I would love to know the exact location on the lower extremity of where the pain is. I want to know the nature of the pain. I want to know if there's radiation of the pain. I want to also know the quality of the pain and the severity of the pain. So like, rating it 1 through 10. Um, I would love to know like the character, like I can't hear you. You went muted.
Hmm. Can you hear
There
me
you go.
now?
Yeah.
Why would you want to know about the nature of the pain?
So I want to know the nature of the pain because I want to like, so is it sharp? Is it dull? Is it burning or electric? Because that could tell me, well, is this a nociceptive type of pain? Is this a neuropathic type pain? Because, neuropathic leads to more like a neurological type of thing that's going on versus like if she's nociceptive pain or somatic pain, is this more bony or is this more musculoskeletal? So that would help a lot as well in this nature.
What else would you like to know about the history?
Other things I'd like to know about the history is exacerbating and alleviating factors, what treatments she's tried. Um, I'd also like to know any associated symptoms, as I mentioned before, numbness and tingling, swelling in the area. I'd also like to know any type of changes in her function. What's her prior level of function? What's her current level of function? I want to know any type of past surgical history, her past medical history, obviously. Um, and
Why
then
would
I'll
her past medical history?
So, just to see if she's been having any type of, maybe she has osteoporosis. I mean, I know how old is she, the patient?
35.
35. Oh, never mind. But no, she could still, like, maybe she had some type of, the female athletic triad where, she had a history of that. She had an eating disorder or something like that. So she's very, like, even though it's a multiple trauma, but I want to know how frail her bone is, was she having a history of osteoporosis where now it's like, this is expected, here. So that's something I want to know if she has that in her past medical history. A little bit of a reach, but still something to know. Does she have any type of congenital history as well? That could be, you know, leading her more prone to any type of fractures or more prone to injury or ligamental
Okay,
injury as well.
on to the physical exam.
Physical exam. Okay, so physical exam, I would like to know basically, I would like to inspect the area of the lower extremity. I want to palpate the area. And when I'm inspecting it and palpating, I'm looking for any tenderness, swelling, any skin changes, any open wounds per se. I would love to know basically, moving on to musculoskeletal range of motion. I would love to know her muscle strength exam. I would love to know sensation as well. Um, Depending on the location of the area that's hurting, I would love to know above and below the joint. Is she having knee pain? Is she having ankle pain? Or if it's at the ankle, knowing above the knee and into the metatarsals in the foot. Or if it's
What is sensation going to tell you on exam?
what is what? Excuse me.
Why are you why are you wanting to know more about the sensation? What is that going to tell you?
So sensation is going to tell me if her peripheral nerves are intact, because if she had a fracture, because she had possibly a laceration to one of her peripheral nerves, what distribution is it in, even if she's lacking sensation, is it coming from the peripheral nerve system proximally, or maybe during her accident, did she have some type of trauma to her lower back? Because maybe she had a fracture in her back and now she's having some type of compression or a radiculopathy or some radiculitis or maybe a lumbosacroplexopathy per se. So that's what I want to know about sensation as well. If is it more generalized or is it a specific dermatome that's really hurting her or that's causing her pain at this time?
Let's move on. The patient has pain in the location of her prior ankle fracture
Mm.
with with hypersensitivity with distal movements or light touch to the ankle. There is redness and swelling in the left lower extremity around her areas of pain. What is your differential diagnosis?
So because she has a history of prior high ankle sprains and she also has the trauma, could she have complex regional pain syndrome? And this would be type 2 because of a known injury to a peripheral nerve. That's my number one, especially that she has the allodynia and the hypersensitivity to touch. Other differential diagnosis, she is a female and she is young. Could she, less likely, but could she have some type of rheumatoid arthritis? Rheumatoid arthritis is known to take place in the ankles as well. Could she have some type of infection per se? Did she have some type of trauma leading to infection in the area, whether that's wound? Could she have some type of lateral ankle sprain again, or a medial ankle sprain per se? Could she have an ankle sprain that leads to a fracture of the fibula, Misinovo? I forget know how to pronounce it, but it starts with the M, Misinovi fracture. So that's another differential diagnosis. Could she have some type of ligamentous injury to her to the in the foot? Um,
What imaging studies would you like to order?
So at this point, I would definitely like to have an X-ray to see if any fractures or dislocations per se. I would love to get an MRI. Oh, because another thing on the MRI, could she have, any type of ligament damage, or could she have some type of Achilles injury around, this is around the ankle per se? You never know. I think so MRI, X-rays, EMG would be a great to rule out any type of neuropathy that she's having in the ankle. Oh, and because she complex regional pain syndrome, I would love to get her labs first of all to rule out infections, so CBC, CMP, ESR, and ESR
What are you
and
looking for on a trip?
what am I looking for on what?
The CMP.
The for CMP, that's a good question. So let me think about it. Well, I mean, specifically on CMP, maybe I'm looking at, her creatinine and her BUN levels, because if there's swelling in the area, could it not only be immediate swelling, but could it be because she has some type of kidney issues? We never know. So that's the only thing I'd be kind of looking at, the CMP. So maybe a BMP, not a CMP.
Any other studies you would like to order?
I think that I mentioned EMG. Oh yeah. Sorry. So studies that I would like to order, if complex regional pain syndrome is thing, maybe we could send her to get a stellate ganglion block, because to rule that out, to see she has the ipsilateral Horner syndrome that's affected to that. Bone scans are actually good to use for complex regional pain syndrome, or triple bone scan. Yeah, for complex regional pain syndrome as well.
Triple phase bone scan.
Huh?
What are you looking for on triple phase bone scan?
So I'm looking for, in the triple phase, the first and second phase are not going to do anything, but the third one is going to have reuptake from the bone, and that's going to tell me if it's positive or not.
Anything else?
No.
Okay. Patient is found to have increased uptake on third phase of triple phase bone scan and diagnosed with CRPS. What is your initial treatment plan?
So my initial treatment plan is range of, because it just depends on what stage she's in. Is she in the first, second, or third stage? I think the biggest thing is to prevent atrophy, because once she's in the atrophic phase, that's, it's a lot of pain for the patient to go through. So range of motion is very, very, very important. Mobilization is very important. Posturing is very important as well. Strengthening is very important. So we're not having some type of atrophy of the muscles. Medications to help. So whether that's Tylenol, conservative non-opioid management. So Tylenol first, NSAIDs will definitely help. There has been studies that corticosteroids definitely could help, 60 to 80 milligrams from 2 to 3 weeks actually, for a complex regional pain syndrome is another option we can have as well. But most important is just the range of motion. And obviously, at the end of the day, if she's an adult, she's 35-year-old, sympathetic blocks is what basically we use, even though she has a a poor prognosis, but the sympathetic blocks is kind of the go-to for that as well, for management.
Anything else?
For management. I will also referrals to, I don't know if I said it, but maybe indirectly, for referrals to physical therapy for all the range of motion posturing, referral to pain management for the stellate ganglion blocks, just education for the patient on, like I said, how the importance of home exercises is. Trying to remember anything else. She's going to have a lot of psychosocial issues likely due to the lung pain, so maybe a referral to psychology as well, or psychologists, so she can basically talk about her mental health. That's about
Anything
it. That's it.
The patient reports that their employer is no longer allowing them to have modified duty. What next steps do you take?
Can you repeat that question one more time?
Sorry about that. The patient reports that their employer is no longer allowing them to have modified duty. What next steps do you take?
So the next steps I would take for the patient is to maybe ask her, well, what is, in your steps, because I'm not familiar, what is, what is your goals for work? The fact that basically they're not allowing them to have modified duty, to basically brainstorm of different ways of you could be useful at work, or maybe thinking about alternative jobs that she may be able to do to provide for herself and her family, but also being happy with the job that she has. I also do think that she should be allowed and benefit to take the time, whether it's looking into her work about time off per se, or getting compensated while her time is off, while she's trying to recover from her injury. I think it'd be a great time to talk with our social management or social worker to see what are documents or things that she could provide, or maybe notes from myself that we could provide for her to basically give to her employer to let this patient be continued to be on modified duty as well.
Any other steps you would like to take?
Other steps is maybe, I don't know about, no, I wouldn't talk to the employer. I just write a note to them, but that's it. No, that's all I would do.
The patient is stating that all medications have not helped. However, they went to the ED for pain and was given Norco with great relief. They are now asking if they can be prescribed Norco for the pain.
So,
Doc, I went to the ED and the Norco really helped. Can I please get some?
So, okay, I mean, I understand why narco would help. Narcotics are basically used for, are really used for, acute pain, or what we're trying to do. We can use for chronic pain as well. I think that we need to still try conservative management first. I know you went to the ED, but if I was there, I'd definitely try to do conservative management first, because that's what's going to help you in the long run. I'm not completely saying no to narcotics. I'm just saying right now, let's see how you do with conservative management. And if that doesn't help, when we do a follow-up, maybe 3 to 4 months, or even there's other things we can do before we just jump straight to narcotics, because narcotics isn't always the best thing for patients in the long run, due to many side effects that it has.
But it's the only thing that's helped out of the medications you've given me.
So if it's the only thing that's helped besides medications, medications are not the only thing that are supposed to help with your pain. There are different modalities we can do. For example, I could send you to physical therapy. We can try some TENS units, some heat modalities, ultrasound modalities that can help with your pain. There are different exercises that you can do to help with your pain as well. It's not only about medications, but there's things outside of medications that we can help you with to help treat your pain. So I understand. I know you're frustrated. I get that. But if you could just please work with me, and we could try to use some outside of the medical treatment to help your pain.
I'll work with you. Thank you.
Thank you.
Okay. Good job.
Thank you. I felt better about that one than the first one.
So the biggest thing for these, and I think you did a good job, and I was trying to ask some questions to help with your thought process along, is with this newer format that they have, is really, you want to hit your main points, but really want to hear your thought process.
Gotcha.
So as you're asking old carts, this one was very specific, like it's pain, so you're able to kind of more do the old carts. They may not all be that straightforward.
Yeah.
But as you're doing that, explain your thought process. That's all they're wanting. They know that you know how to take a history. But, I want to know, location, but also severity and the nature type of pain, because if it's burning, it may make me think more nerve pain, exactly like you said when I asked, like,
Gotcha.
why did you ask about nature of pain?
Gotcha. So can I ask a question? If they ask why you want to do that, is that bad, or should I be saying, oh, I want to do this because of this, or should I just, what method is the best way to do?
Know about, I think I can only speak personally, but I would go through a little bit, but kind of just throw in points like, I want to look for these things, as this is going to indicate that. I would explain it as you go. They're still going to win questions, but they may not, if they're able to see your thought process and the critical thinking behind why you're asking what you're asking, because you don't want to just say, like, I want to know their past medical history, I want to know their past surgical history. You want to indicate why, and that's why I asked, because I wanted to hear your thought process.
Gotcha.
That's just, it used to just kind of be check marks. Oh, they asked for past medical. No, now they want to know, like, your critical thinking. What about their past medical history?
Yeah, so it's not just memorization, but like, are you actually thinking about something?
Your critical thought process.
Yeah.
Critical. And with the physical exam, you did good. So they want to, it's more of pertinent things. Like, they're going to move you along.
Yeah.
So you want to make sure you hit your pertinent things, but explain it. So I would first like to see where it is. I would like to inspect it. I would like to inspect it to see, is there any redness? Is there any swelling? I would like to look at range of motion, both active and passively, see if pain is limiting any of these. I would like to do these special tests, as I'm looking for ligamentous injury versus blah, blah, blah. Just explain your thought process behind it.
Gotcha.
And you did as I asked.
Okay.
And they may ask those things. If they ask, it is not bad. They are going to ask. Yeah. But you want to give them as much as your thought process. They are also going to ask, and that's why I kept doing it, is there anything else? Yeah. There will be some that will just keep asking that. Yeah. And so you get to a point where you just be confident in yourself. You can take a second to think, but they are going to ask you, regardless if you have everything or not. Anything else? Yeah. Nothing else. That is all. But yeah, that's good. But when you're preparing, especially for the HPI and the physical exam, have kind of a checklist in your mind and make sure you're hitting all of those points, but try to do pertinent ones first.
Gotcha.
If that makes sense.
Yeah. That makes sense.
Okay. And then looking at part B, it's more of your medical knowledge. So what's your differential diagnosis? My biggest recommendation, you did fantastic on it. Biggest recommendation is kind of write down your differentials as you go, because when you are talking about your medical plan or what workup you want to do, you want to make sure you have a workup for each of these things.
Yeah. Gotcha.
Because you said CRPS was your number one, and I agree, you're going to get an x-ray first, but you want to make sure you don't forget that triple phase bone scan, and that was the last thing you mentioned.
I know, scattered. I know.
You got it. Doesn't matter. But I'm just saying, like, for organization purposes, kind of write down your differential diagnoses, because then you can think through your plan, and you know that you have a plan for each of your differentials.
So we could write during this test, because I haven't been writing anything really.
you're going to have 6 cases all rapid fire back to back. It may be helpful to just jog some things down, like what, just like not the whole sentence what they're writing, but like bilateral, like pain, and just kind of the key things.
Gotcha.
Each person does it differently and best how they do it, but once you start getting to that 4th and 5th case, you may get things a little mixed up.
Gotcha.
And it kind of just allows you to focus so you don't have to like stare at them.
Gotcha. Yeah, gotcha.
The only differential that I had on this would have been HO because it was a trauma.
Gotcha.
The only one. Otherwise,
I missed HO. I missed it.
DVT either.
I didn't say DVT. No. So okay. DVT, HO. DVT would have been a good one. Yeah.
But you said the fracture, CRPS, cellulitis. So those are big ones. Patients found to have so perfect on what are you looking for on triple phase bone scan? CRPS, 3rd phase, HO, depends on kind of where you're at in the process.
Gotcha.
So you nailed that. That was awesome. And then your treatment plan was great. My only thing with the treatment plan was you said stellate ganglion block, and wouldn't it be a lumbar plexus?
Yeah.
Pain. I'm asking to confirm.
Yeah, it would be. I was just because it's lower extremity, not upper extremity. My bad. Yes. Okay. I said sympathetic block at the. I did say. What happened?
You did.
Yeah, I think I just. And then you word vomit. That's what I got.
No, that's okay. You got it. But yes, always try and list in your treatment plan first. It's exactly what you did, but just think of and then go progressively more not conservative.
Gotcha.
As you did, as you said, start out with PTOT, range of motion, desensitization techniques, pain meds, and then you said the block at the end. So keeping that format in your head.
Okay.
And that's what you did.
Okay.
And then that's one I'm asking anything else. There wasn't anything else, but it's just they do that to kind of just throw off your confidence. But
have that confidence,
you've been doing this. Just be confident.
Gotcha.
Then with the employer one, I will say they have on the ABP on our website, they have some really good examples of this one.
Yeah.
And find out you are down the right track. See if there's a social worker involved. But if it's like workman's comp, you can talk with the employer and things like that. Try to get a little bit more. Other things you could have just said is like, what is work saying? Is there any way we can work with them? Is there anything I can do to try to take the appropriate route, if appropriate, and able to talk with work about how we can help you stay on modified duty. There's other things you can do within what you want to do. But I do. Going back to the treatment plan as well. That's something I didn't have. But yeah, that you did good with the getting back to work. Just those are some of the things I would say, because there's somebody that started a new job and they weren't working when this happened, or this is all through workman's comp and things like that. So it might be a little.
Okay.
And then with the pain medications, at the end, them asking for Norco, you did good on it. The biggest thing with these the biggest thing with these, the Part E part is really just remaining professional and calm and explaining. But I was looking a little bit for explaining that Norco is not indicated with this specific type of pain, or opioids are not, and explaining to them what the risks are. And then tying it back, I loved how whenever I asked a question and you responded with, let's try these we have other options. We have other non-medication options that are found to be very helpful, and let's continue to work together. That's what they're looking for. It's just kind of that personal, interpersonal relationship with the patient communication as well. So that was very good.
But just listing, because, you know, I should have went, I was like, you know, narcotics are not always great for you. And yeah, I should have from then went on to the risk about it. But yeah, I get you. You know,
Yeah.
I think I also I'm trying to work on my medical jargon, not saying too many big words, you know what I'm saying? But like, I get that. That's something I could have went into, because that's not really, the patient should know the risk of taking opioids specifically.
Yeah, and I think, for example, how I would have approached it a little bit, because remember, this is boards. They want the board answer.
Yeah.
We know that opioids can be used mostly acutely. We try not to use them chronically, but kind of the board answer. And so what are they looking for? Is Norco treated? Do we use Norco for CRPS? Yeah. Not board answer, right? And so kind of looking at, I'm so sorry you're having a lot of pain. I understand that this has helped you. Let's, here's your different options, the reasons we don't use it, blah, 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 blah.
Gotcha.
Yeah, but you did very well. That's
Thank you.
Just let your thought process, let them see your thinking. You've been doing it for so long. You have all the, just let them see your knowledge.
Gotcha. Thanks. So, but overall, okay, just improvements on that, right?
I think you, especially for y'all not doing these regularly in your first time, I thought you did really well.
Thank you. I appreciate it. I'm going to continue to work on it, so I appreciate that.
Yeah, awesome job.
Thank you.
You're welcome. I think they're joining us.
I think so. I think I could text Nick. I don't think you're going to do Warm Springs anymore, huh? You're stuck with your thumbs up. Let me send you a picture.
What?
You're stuck in the with the thumbs up. Your figures. I'm gonna send it to you. I was just like, I don't think you're gonna pick Warm Springs anymore.
Can you hear me at all?
I can hear you. It was just times where it was just like, the audio was fine. It's what saved. Your picture would lag a lot, and then sometimes you would talk and it would lag, and then it would speed up your talking just to catch up, which is hilarious.
Weird.
Yeah.
Nick and I were both going to jump back on just to see if you guys had any closing thoughts or feedback for us.
Yeah, Nick, you have any closing thoughts or feedback?
Dr. P and I both like feedback.
Feedback for you?
Were the cases good? Did you think they were?
Yeah.
I think the cases were great. I think I'm lucky because it was all pain related, so I was like, yes. I think honestly, I was talking to Dr. P about it. It's I wish there was more attendings and more residents on the side. And I know you guys came from the same institution. It is nice to have this. I did this because before we leave, we're not going to have this again. We're going to be talking to each other and practicing. So I just wanted to do this, not because I was like, oh, I'm going to do great. I just want to see where I'm at, and hearing your feedback from Dr. Verman and Dr. Pollifrone, it's great. So I think you guys are doing awesome. I know it's limited, so I don't think this is a fair feedback, but maybe it would have been nice to not
more variety in cases.
More variety of cases. But like I said, I think it's because it's only 2. So I think if there was more residents here, more likely chances I would have got a different type of case.
Yeah. Well, and
Deji,
honestly, it's the attending representation, because we write cases off of things we've seen or that we're our strengths.
Yes.
Also, Deji, I didn't get any pain. I don't know. You're so lucky. Yours are Mine were way different. So
Yeah, well, that guy.
anyway,
I
you'll
went
see
by
you'll
the-
see if you watch them.
I went by the order I wrote it in. I did not plan for y'all to each get those. I just went by the order of my page. It just
I
happened.
thought it was planned because Dr. Ruman's interprofessional skills, like when she's, I'm gonna sue these people. I was like, this is definitely a minority talking. So like, is it talking?
The rich white folk.
I was just like, this is great. Like,
The little white attending is going to complain about the rich white
I was
folk.
just like, this has to be planned, but I'm glad it wasn't. It was great. I think it's gonna be.
Yeah.
I think you guys should definitely talk with Dr. Seidel. I know he can't be part of it. Maybe for next year, just I don't know why the persona is like we don't want to do oral boards. I just would like to take that persona away and maybe improve that because it is. I think it is beneficial. I know the thought is, well, it's a year from now. Why are we doing it? But like, I think it's still beneficial.
Yeah.
I know me and Dr. Ruman came from the same program where we did oral boards every month.
Yeah.
With tactics, and I do really think it helps with like real life boards of even just like you practice in front of your peers. So like it's all friends, right? You're not ashamed of making mistakes. No one's going to make fun of you because everybody's learning, and on their end they don't know it either. And it's really just seeing like where you need to improve, or even it's the talking, right? Like talking in front of a screen or people, however, if they change it in the future, that's the hard part of this, that you just get more comfortable by doing it.
Right. And you know, you're not going to see the exact same cases again. So it's less about the specific cases and it's more about your ability to think broadly and to stay on time and to recover when you have the dope moments, you know, of like, of course I didn't ask that. Like,
yeah.
That was
And
great.
to bring on that part, I don't know if I told y'all or if Dr. Ruman did during the feedback, but like each ABCDE is scored separately. So if you mess up, remember, they just want to hear your thought process and all of your critical thinking. So you may get some parts, but if they move on and they're like, oh, they were diagnosed with this and you thought it was something else, forget it. Move on. It's all scored separately. It doesn't, because you did do the best on one part, doesn't affect the rest of the case.
Okay.
Right. It's the mental game and being able to reset yourself quickly. Because it's normal to get caught up in the, of course I missed that, or you know, but then you have a trickle effect because you lose points on the next domains.
Yeah.
And so trying to think about it as, yes, this is one examiner, one case, but I have 5 questions, you know, I think helps.
Yeah. Well, thanks so much for doing this for us. This was really super helpful.
I thought y'all were awesome.
I was going to say, one of the things I've